imaging in the skin color. So the stage is yours.
Thank you for the introduction. So here I am again. Okay, so I will talk about challenging cases and dermoscopy. So first of all, we have to start with this. I think we agree that this one is psoriasis and this one is vitiligo. So in most cases, clinical examination is enough. Okay. So having said that, let's move on. Okay. Sometimes, okay, clinical examination is not enough. We have to do biopsy. And, you know, sometimes patients may be unhappy with this. Of course, in pediatric population, but you talked about pediatric population, so it's not my talk, it's not my topic. I would like to talk about two challenging situations, face and genitalia. Okay? These patients don't want to do biopsy generally, okay, because of, you know, scars or other reasons. Okay. And sometimes these conditions may look very similar among each other. So let's start with the face. Here we have two patients. Both of them were referred to me for psoriasis or seborrheic dermatitis, and I think it's a reasonable option, okay? But just one of them has actually seborrheic dermatitis, but we will come back to these cases later. Both these patients came to me with a diagnosis of suspicion of rosacea. Is there anyone else that, you know, do you have any other possible diagnosis? Are you happy with rosacea in both these cases? No. Okay. So now, let's see the dermoscopic clues of these conditions, of facial inflammatory dermatosis. I already talked about this condition this morning. What do we have here? We have these very nice polygonal vessels, okay, histologically corresponding to the dilation of subpapillary vascular plexus here, okay? And these vessels are nearly pathognomonic for rosacea, okay? Seborrheic dermatitis. In seborrheic dermatitis, we have two main findings. Clustered dotted vessels corresponding to dilated vessels in irregularly elongated dermal papillae. Please note that on the face, we have mainly dotted vessels. On scalp, as I told you this morning, we have branching vessels, okay? There is the difference, because on the scalp, you know, the dermal-epidermal junction is flat, okay? And then we have yellow scales, similarly to the scalp, because we have spongiosis and hyperkeratosis. So, two clues. Then we have, I think, the most famous condition under dermoscopy, which is grammatous dermatosis, sarcoidosis, okay? In sarcoidosis, we mainly have orange color, okay? This is, of course, an optical effect. This orange color is due to the presence of a very compact cellular infiltrate. We called this optical effect the mass effect, okay? But we also have something else. We have these very focused vessels, no matter the morphology, okay? They are very, very focused. They may be linear curved, linear branching, but the most important thing is that they are very focused. Because, you know, the dermal infiltrate pushes the vessels upwards, so towards our eyes, so they appear more focused. Okay. There is another condition that may, you know, show orange color on the face, which is granuloma faciale. Granuloma faciale is not, of course, a granulomatous condition. It is a leukocytoclastic vasculitis, mainly involving the face, with a fibrotic evolution. And also in this condition, we have orange. But please note the vessels. The vessels are blurred. So no sharp vessels, okay? Because here we do not have, you know, the cellular infiltrate pushing the vessels upwards. Then, discal lupus. I already talked about this condition this morning. What do we have? We have follicular findings, especially follicular plaques, because in this condition we have follicular hyperkeratosis. We call this pattern strawberry pattern because we have an erythematous red background, okay? But the most important thing is that we have the follicular plaques. And then we have another condition, which is pretty common actually on the face, which is demodicosis. In this condition, we still have follicular plaques, but they are protruding, okay? Some authors call this finding Demodex tails, but of course they are not the tails of the Demodex. These protruding follicular plaques correspond to the presence of a mixture of mites plus keratin in the follicles. Okay? Here we are. Okay, so let's remember 4 findings for the face. Polygonal vessels are indicative of rosacea, yellow scales and patchy dotted vessels for seborrheic dermatitis, and then we have orange color and follicular plaques. When we have orange color, the question is, are they focused or not? If they are focused, we have to think about a dermatosis, mainly sarcoidosis, but also other conditions. If they are not focused, we have to think about granuloma faciale. In the case of follicular plaques, the question is, are they protruding or not? If we have protruding follicular plaques, so the most likely diagnosis is demodicosis, otherwise discoid lupus. Okay? So, now, with this in mind, let's come back to our patients. I told you that both these cases were referred for the suspicion of seborrheic dermatitis, and I think it's reasonable. But which one is seborrheic dermatitis, in your opinion? The one on the right, on the left? Right? Very good. Indeed, it was on the right. What do we have here? We have yellow scales and patchy dotted vessels. Okay? On the left, what do we have? Follicular plaques, but protruding. So, demodicosis. Huh? Unbelievable, but it's very easy to diagnose by using dermoscopy. Okay, demodicosis, seborrheic dermatitis. The other 2 cases, both of these patients had a suspicion of rosacea. Which one is rosacea? It's a bit different. Okay, the one on the right, always on the right. Okay, okay. Let's see dermoscopy. What do we have here? Which color we have here? Orange. We have focused vessels. So actually this was sarcoidosis. And on the right we have follicular plaques. So discoid lupus. This was sarcoidosis lupus pernia, which is a little bit different from the classical sarcoidosis. And on the right, discoid lupus. Okay, so let's see another couple of cases. This lady came to me for another problem, but you know, I'm pretty curious, and I noticed these lesions. Maybe they are nothing; they're just pimples. But I used my dermoscopy, and what I saw is this. What's this? Follicular plaques. So what's this? Discoid lupus. Yeah. In early stages, we do not have, the classic roundish lesions. So this was discoid lupus. Okay? So very nice because, it was a very subtle case. Sometimes, subtle cases go unnoticed. But with dermoscopy, we can catch them. Okay, another case. This was a 62-year-old female with this erythema for 3 weeks, asymptomatic. What's the differential diagnosis here? The most common ones. Seborrheic dermatitis? No? Rosacea? Okay, we agree. Rosacea and seborrheic dermatitis. But it's pretty difficult to say, yeah, here may look like seborrheic dermatitis, but I used my dermoscopy here, and this was what I saw. So I think it's clear-cut, the vascular pattern, this polygonal vascular findings, okay? So this was rosacea, okay? I'm talking about this area, okay? So another case. This was a little bit more challenging. This lady had these lesions for 2 months, treated with metronidazole gel, okay, with no improvement. Is there any idea about the diagnosis? What? No, I'm talking about the ones I showed you. This, roundish erythematous papules, patches, plaques, Sarcoidosis, it could be. Okay, we thought about sarcoidosis, but also a strange form of rosacea, maybe a granulomatous rosacea. Huh? Okay, let's take a look at dermoscopy. Okay, so now the color here is orange. Okay, so now the question is, do we have focused vessels or not? No. So the diagnosis is granuloma faciale. Correct. I think it's impossible to make the diagnosis here just by clinical examination. Huh? But with dermoscopy, we have something additional. Okay, this is very nice. I think that it cannot be other than psoriasis. Huh? I think that we all agree this is psoriasis, come on. Huh? Okay, she was treated with a topical steroid with transient improvements. But, you know, these were our differential diagnosis. Come on, psoriasis, strange form of seborrheic dermatitis. Okay, but let me show you dermoscopy. Yeah, which color we have here? Orange. Do we have focused vessels? Of course we have. So this is sarcoidosis. Unbelievable. You know, sarcoidosis is the greatest mimicker, I think, in dermatology. It may look like everything, and this was indeed sarcoidosis. This case is very nice. I have to show it to you. This man had these lesions for 4 months, and he didn't want to come to the doctor. But, you know, his wife was so scared because, you know, he's scary. Huh? And finally, he came to us, and our differential diagnosis here were psoriasis or a strange form of sarcoidosis. Do you agree? Huh? Is there any other diagnosis possible? No. Yes? Okay, let's take a look at dermoscopy. What do we have here? We have everything, of course, but what do we have here? This very nice protruding follicular plaques. So this was demodicosis. This was demodicosis. Unbelievable. Yeah. So let's move to genitalia, and I would like to underline the differential diagnosis between erythroplasia and chronic balanitis. They may look very similar. Okay, these cases are pretty similar. Of course, we can have an idea, okay? I don't know if you have the diagnosis in mind, but it's pretty challenging. Even these 2 cases, to me, look very, very similar. But we will come back. Even these cases, you know, they are quite unspecific. We cannot do the diagnosis only by clinical examination. But let's take a look at the demoscopic clues of chronic balanitis and erythroplasia. What do we have in Zoom balanitis, which is, in my view, the most common form of balanitis? We have orange color again, because we have hemosiderin deposits, similarly to granuloma faciale. But we also have these very nice linear curved vessels, okay, which are very focused, because in Zoom balanitis we have a thinning of the epithelium, okay? Psoriatic balanitis, the pattern is the same as the cutaneous counterpart, so we have dotted vessels distributed in a uniform pattern, okay? Of course, we do not have scaling because of the humidity of the region, of the area. Candida balanitis, we have specific vessels, but the most important finding is the presence of this sparse white coating, which corresponds to the presence of the fungal colonies by themselves, okay? Of course, the pattern is similar to the one of other forms of candidiasis. And then we have erythroplasia of Kera. What do we have here? Here we have glomerular vessels. This pattern is similar to Bowen's disease, which is the cutaneous counterpart. Here, what do we have? We have these glomerular vessels arranged in a clustered pattern, okay? But actually, on genitalia, the distribution is a little bit different. We may have this clustered pattern, but in most cases, these vessels are distributed in a diffuse way, okay? Similarly to psoriasis, okay? So by using handheld dermoscope, it might be quite difficult to differentiate the glomerular vessels of erythroplasia of Kera and the dotted vessels of psoriasis. But there are some tips. In psoriasis, we are talking about an inflammatory conditions. Vessels are very homogeneous among each other in terms of, size, shape, and distance among each other. In erythroplasia of Kera, we are talking about a tumor, okay? Vessels are not homogeneous, are different among each other in terms of size, shape, and distance among each other, okay? So these are the tips to differentiate the vessels. Just a few words about lichen sclerosus. Here we have fibrosis, so we may see bright white areas. And non-specific irritative balanitis, of course, it's a diagnosis of exclusion. We just see linear, irregularly distributed vessels, blurred vessels. So the main finding is that we do not have anything else, okay? So this is the summary, okay? So let's remember orange for zoom balanitis, bright color for lichen sclerosus, white coating for candidal balanitis, and vessels, glomerular vessels for erythroplasia, dotted vessels for psoriasis, and focused curved vessels for zoom balanitis. Okay, so let's come back to our cases. Let's see dermoscopy. So what do we have here? Dots, okay? Very homogeneous. So the diagnosis? Psoriasis, right. And on the right, it's simple. We have orange. We have linear curved, focused, sharp vessels. So the diagnosis is zooms balanitis. Yes, bravissimi. And then even these two cases, here it's a little bit more challenging because we have, glomerular here vessels, but I'd say even dotted at a lower magnification. Even here we have dotted vessels. So we have to think about the tips I gave you before. So here vessels are very homogeneous among each other. Here they are different among each other. Okay? So on the left we have erythroplasia, on the right psoriasis. Other two cases. So which color do we see here? White, bright white, a lot of it. Okay? On the right we have orange, and we have these linear curved vessels, focused vessels. So which is the diagnosis on the left? White, fibrosis, lichen sclerosus. On the right, orange color, zoom balanitis. But we do have something else here. In both these cases, we have clustered glomerular vessels. So actually, these were erythroplasia of Kera, both these cases, on an inflammatory background. Okay? It may happen. We have to be very careful, and it is important, dermoscopy also for guiding the biopsy, because if we take the biopsy here, the pathologist won't say, yes, it's erythroplasia, but if we take it here, okay, the pathologist will be able to do the diagnosis, okay? So we have to update the dermoscopic overview. Please don't forget overlaps. Okay, if I have some time, I will show you another couple of cases. The female counterpart, okay, it's to me it's more difficult. I don't know what it is, but if we use dermoscopy, what it is? Zooms pulvitis. And here, very unspecific from a clinical point of view. What do we see here? Vessels, okay, which are different among each other. So this is erythroplasia. And then this is the last case. Then I finished. This came to us and was visited by one of my residents. He called me and he asked me, what do you think? I was in a rush, so I told him, come on, cut it out because it's a tumor. Okay, we did it. And do you know what the diagnosis was? What?
Fixed drug eruption?
No. It was zoom balanitis. Come on, I called the pathologist. I told him, you are crazy. We are friends. I told him, you are crazy. It's not zoom balanitis. Okay, but my resident took a photo, a dermoscopic photo, and actually here I had orange color. And I didn't know, but there is a rare variant of zumbalanitis which is called nodular zumbalanitis. Come on, it's really rare. But, you know, dermoscopy showed something, but I didn't see the dermoscopic, you know, the dermoscopy of the patient. So we did this mistake, but of course, if we have a nodular lesion, we have to take a biopsy, come on. That's it. Thank you very much.
Thank you, Professor Enzo, for enlightening lecture.